Hello, today we will talk about the introduction, overview, and the management of the aortic stenosis. The aortic valve are present between the left ventricle and the aorta. Nerving or thickening of these aortic valves can lead to the obstruction in the left ventricular outflow, which significantly decrease the cardiac output. Mild and moderate type of aortic stenosis is usually asymptomatic. The area on the chest at which the heart valve are audible and are present are aortic valve, pulmonary valve, tricuspid valve, and the mitral valve. With the aortic valve audible at the right second intercostal space parasternally, and the pulmonary valve audible at the left second intercostal space parasternally. The tricuspid valve are audible at the left fourth intercostal space parasternally, while the mitral valve are audible at the left fifth intercostal space at the mid clavicular line. The pulmonary valve which control the oxygen poor blood from the heart to the lung have three leaflets. Tricuspid valve which is present between the right atrium and the right ventricle consists of three leaflets as well. The mitral valve which is present between the left atrium and the left ventricle consists of two leaflets, also called the bicuspid valve. During the cardiac cycle, the aortic valve are open as well as the pulmonary valve, pumping the blood effectively and efficiently into the systemic circulation and in the lungs, while the tricuspid valve and the mitral valve are closed. Normal healthy aortic valve pump the blood from the left ventricle into the systemic circulation, while the heart valve, which gets stenosed over time, does not pump the blood efficiently into the systemic circulation. Even when the aortic valve open to pump the blood, the stenosis which already developed in leads to the obstruction of the blood flow, causing a decrease in the blood flow, which eventually lead to a decrease in the cardiac output. The sign and symptom of the aortic stenosis are the cardinal features, which are because of the decrease in the cardiac output. Three of the most important sign and symptoms are exertional dizziness or syncope, exertional dyspnea, and the angina on the exertion. The examination of the aortic stenosis can be done by palpating the carotid artery around the neck, which gives a slow rate of rise in the carotid artery pulse. While the normal aortic pulse is fast, with a pulse pressure of 50 mm of mercury, but in aortic stenosis, the pulse lies very slow and the pulse is weak with a pulse pressure of 30 mm of mercury. On auscultation in the aortic stenosis, by putting the stethoscope at the right second intercostal space parasternally, heart sounds are audible, which are very reduced in the frequency and intensity. Also, soft or absent S2 heart sounds are audible, and S4 heart sounds, which also called the atrial systole or the atrial gallop, are produced because of the concentric hypertrophy, which eventually lead to the stenosis. The murmur which produced in the aortic stenosis present between the S1 and S2, where at S1 when AV valve closed, there is ejection click and aortic turbulence in which increases first and then decreases eventually ending at the S2 level, producing a murmur called the ejection systolic murmur, also systolic click crescendo decrescendo murmurs. Five major etiologies of the aortic stenosis involve the congenital abnormal valve, which involve the unicuspid or bicuspid valve. A unicuspid valve is shown here. Also, people who are less than 65-year-old, bicuspid aortic valve are common, which eventually lead to the calcification. Or people who are more than 65-year-old, degenerative calcifications are common. Other than that, the tricuspid valve calcification or a patient who have been suffer from the rheumatic heart disease can develop the scarring and eventually leading to the stenosis of the aortic valve. In the investigation of the aortic stenosis, the most common investigation performed is electrocardiogram, which show a left ventricular hypertrophy. In lead V5 and V6, a convex ST segment with or without septal Q wave is seen. Cardiac catheterization can also be performed in patients. More commonly, it is performed into the femoral artery and it can also perform into the radial artery as well. A cardiac catheter is passed from the femoral artery into the coronary artery for the better visualization of the aorta. A transthoracic endocardiogram may also be performed and is gold standard in a patient with valvular heart disease. The management of the aortic stenosis is done according to the symptom of the patient. If the patient is asymptomatic, we only observe the patient as a general rule. But if the patient is asymptomatic with a valvular gradient of 40 mm of mercury with a left ventricular systolic dysfunction, surgery is indicated. And symptomatic patient, the surgery is indicated, which is valve replacement surgery. In aortic stenosis, valve replacement is performed depending on the age of the patient. Mechanical valve replacement is performed mostly in the younger individual and it lasts longer, while a bioprosthetic valve replacement surgery can also be performed. Short long term anticoagulants and antibiotics are given in those patients who are at risk of infection or may develop complications following the valve replacement surgery. While the patients who are inoperable, a balloon valvuloplasty is performed in which a balloon is inserted into the valve which lead to the opening and dilation of that valve. Following a balloon valvuloplasty, a transcatheter valve replacement can also be performed in which a catheter is inserted into the valve.